Assalamualaikum and a very good morning to everyone. Thank you for joining us early today for our breakfast at Health sessions. So I'll be the moderator for the first sessions. I'm Dr. Faisal from Department of Orthopedic Surgery, University Malaya. So the first speaker is my colleague, Professor Dr. Azlina Amir Abbas. She's the consultant orthopedic surgeons and also the head of our joint replacement unit. She'll be talking about preventing surgical site infections, which is very important in our daily practice. So without further ado, I will let Prof. Azlina to start.
Thank you, Prof. Faisal. Assalamualaikum and good morning, everyone. I hope you're able to see my slides. Okay, so this is the outline of my talk. I'll talk a little bit about surgical site infections, what are the prevention strategies, the concept of an SSI care bundle before I conclude the talk. Surgical site complications encompass everything, including SSI, anything that goes wrong with surgical wounds, such as dehiscence, hypergranulation, maceration, and even adhesive-related skin injury is included under surgical site complications. Before I start on, how do we prevent SSI, I'd like to present a case that probably will highlight to you why it's very important to prevent SSI in the first place. So this is a 32-year-old gentleman who presented to my clinic, quite some time ago in 2017. He had undergone a right knee endoprosthesis for GCT of the tibia 3 years prior to his presentation to me. And he reports that immediately post-op, he's had wound complications that were never ending. He had to undergo multiple wound debridements, prolonged and high doses of IV antibiotics. And his hospital admission, which was supposed to be short, ended up totaling almost 8 to 9 months. Naturally, even after discharge, he had to give up a lot of things, his social life, his studies, and his work. And when it came to examination, the knee was fixed in flexion. There was pus from multiple wounds around the knee. The implant was visible from outside, and distally the foot was sensate and viable. I don't have a clinical picture of him at that time in 2017, but from the x-rays that you can see, the top two of the femur, there's radiological evidence of osteomyelitis. And in the lower two photos of the x-rays, you can tell why the implant is visible. There's no soft tissue shadow at all to the front of the implant. Okay, so that part is what's visible to the outside world. So he was diagnosed with prosthetic joint infections. And actually, the history was over the last 2 years since he was discharged, he's been going around different doctors to see what they can offer him for his infected knee. So the 3 options that were given to him by multiple surgeons were remove the implant, fill the gap with a cement spacer, and then maybe later, once the infection is all settled, do a new knee replacement. But that would be challenging because 1, it's a prolonged infection. Number 2 is you will need a flap. You will need to reconstruct the extensor mechanism of the knee. So the outcomes might not be so great. The second option was to remove implant, fuse the knee, fuse the 2 tibia and the femur together, and then do a lengthening later on. But this also will not be ideal because he won't have a mobile knee anymore. And for lengthening with the degree of bone loss that he had, it would take a very, very long time. And the third option was amputation. He said, let me go think about it. And he disappeared for 2 years. Now, when he did present back 2 years later, he said he had decided it's finally an above knee amputation. He'd had enough of having to clean his implant every day. And in fact, he had started to have symptoms of anemia, and on admission for surgery, his HB was 5. For a 34-year-old, obviously that's dangerously low for anyone actually. So we performed the above knee amputation, thankfully at a level where it was long enough for him to be fitted with a prosthetic leg. And being young and very, very motivated, he was fitted with a prosthetic limb 6 weeks later. This is the video he shared with me the first time he stood up, and he said it felt really good to be able to stand and walk, put his weight, after not being able to do so for the last 5 years. All right. So what is SSI? It's actually an infection related to surgery. occurring up to 30 days post-op, or up to 1 year in patients who receive implants. And it may include one or all of the following 4 criteria. Obviously, past discharge with or without lab confirmation. You're able to isolate the organism aseptically and do CNS. If patient exhibits signs and symptoms of infection, or if you, as a clinician, you feel it's not red, but there's something suspicious, I think it might be SSI, that in itself should start the ball rolling for you to investigate. Infections can be superficial, deep, or organ space. And although this photo shows organ space is abdomen, but the joint is considered an organ space. The source of microorganisms are naturally from a few places. One from the patients, so from their skin, their mucous membranes, or their hollow viscera. Exogenous means they are contaminated by the environment, including the healthcare workers. And distant microorganisms are organisms that are hidden within biofilm, which on occasion would then be released out into systemic circulation. So what happens to patients with SSI? Obviously, they're more likely to be readmitted if they're discharged. And as in the case of Mr. G, he had a very prolonged admission. Patients are more likely to spend more time in intensive care. And with an average of 3% mortality rate, patients who have SSI are more likely to die after surgery. Looking at it from the economic point of view, in the global setting, it is estimated that SSIs will cost countries approximately 3.3 billion US dollars and almost 1 million additional inpatient days annually. And these are direct, its direct cost is sort of easy to calculate because it's the cost of them staying in the ward, cost of nursing, dressing, antibiotics, and what other medications that you have to use. But the indirect costs are the ones that are more difficult to estimate. And again, in the case of Mr. G, there was loss of productivity, there is poor quality of life for this young gentleman, and obviously there was a lot of dissatisfaction. That's global scale. What is it like in Malaysia? Now, the Ministry of Health of Malaysia did a rough calculation. So they looked at the total number of surgeries performed in 2021, mindful that it was during COVID. Obviously, it's not very large numbers, but it's large enough, almost 900,000 cases in 2021. Now, if we extrapolate the numbers based on statistics by WHO and CDC, it is estimated that up to 105,000 of these 900,000 cases would be suffering from an SSI. And the mortality rate could be as high as 3,000 over patients. Now, if you look, there's a study out of HSA-JB, I think, that was published in 2019, where they concluded that patients with SSI needed additional hospitalization of 7 to 10 days on average. Now, if you calculate that hospitalization cost per day in a government hospital is roughly 100 ringgit a day. Just for admission would cost for 2021 20 million ringgit. This does not include the cost of treatment and surgeries, etc. All right. Thankfully, there are many guidelines available in the world. WHO, CDC, nice guidelines in the UK. There's guidelines in Germany, as well as Japan. And regionally as well, which help to guide us on what we can do to prevent surgical site infections. This I show to you are international and regional guidelines. And in Malaysia, the Ministry of Health recently launched in August the Surgical Site Infection Prevention and Surveillance Guideline. The committee for this guideline production were represented by all surgical specialties, the anesthesiologists, infectious diseases consultants from MOH majority. From Ministry of Education were Prof. Sashila and myself, and from MINDEF was Brigadier General Musa from Lumut. All right, so we worked over 2 or 3 years to produce this, and this is, I think, freely available. If you want a copy of it, let me know. I'll be happy to share it with you. If you want to talk about SSI prevention, you obviously need to know what is it you need to address in order to prevent the infection. And if you have to then think of risk factors of SSI, for which there are many. It's roughly divided into intrinsic and extrinsic factors. Intrinsic naturally means it's the patient. And when it comes to patient factors, it could be modifiable or non-modifiable. And extrinsic, again, is whatever that's happening in the environment with the healthcare workers, etc. Now, in most guidelines, when they present to you the different things that you can address, it's roughly divided into pre-op, peri-op, and post-operative phases. So that is how my talk will be formatted, okay, will be presented. So in the pre-operative phase, it's really about trying to look for and identify the different modifiable and non-modifiable factors a patient has. And once you have identified them, be able to optimize the patients, particularly when it comes to modifiable factors. Granted, when it's non-modifiable by nature of its name, it means there's not much you can do about it. But at least if you identify non-modifiable factors, you also would be aware that I need to take extra care with this, let's say, elderly patient, with this patient who's on chemotherapy, with this patient who's had a history of infection in the past. These are some of the non-modifiable factors that we may be faced. So one of the modifiable factors most commonly is diabetes. We do know that the diabetic condition is generally associated with a higher risk for infection. And for surgeries, it is known that if patients have poorly controlled diabetes with HbA1c that's very high, they do have a higher risk of wound complications. So obviously the guidelines is high. You should try to aim for HbA1c of less than 8% for patients for elective surgery. And even in the post-operative period, not only for the diabetic patients, but even the non-diabetic patients, it is actually beneficial to prevent hyperglycemia in this group of patients. Okay. Obesity, again, naturally, higher BMI has a significant risk of infection. And obviously, it's because of the fact that the subcutaneous tissue is very much thicker, there's poor vascularization, your incision length also needs to be bigger, the complexity of the surgery is more. So although this might not be very easy to manage in an acute setting, but if you have one where it's an elective surgery, something that can afford to wait, you should advise your patient to try and lose some weight. Perhaps a referral to dietitian, physiotherapist, or bariatric surgeon may help. And you do need to counsel, if you do need to proceed with surgery when the patient's with a high BMI, you need to counsel them very clearly about the increased risk of complications post-op. Patients, come with many conditions. Some patients are malnourished, some patients are anemic, and actually, in both of these instances, it's useful again to identify them early and try to correct them pre-operatively, especially in elective cases that you can wait. But particularly with anemia, I think if it's a case that you kind of need to do soon, try to optimize their bloods as much as possible in the perioperative period, as well as trying to avoid excessive blood loss during surgery. So with Mr. G, we had to use a tourniquet to reduce his blood loss. We used tranexamic acid, and actually for his HB of 5, we knew that if we were to correct it, immediately post-op, most of it would be, bled out onto the table if we didn't control his bleeding. So we gave him iron infusion post-op, and within a month, his HB had come up very nicely. Smoking and vaping, obviously, active smokers have higher risk of SSI because smoking causes vasoconstriction and therefore delays wound healing. And I know a lot of patients will say, oh, okay, I replace my cigarettes with vapes. They are safer, but actually vapes carry very similar risks to smoking. So again, in elective surgery, you should try to advise your patient to stop smoking, and to really reduce their risk, they need to not stop the day before op, but ideally 3 to 4 weeks prior. And post-op, maybe you could counsel them like, hey, you already stopped for a month. Why don't you stop forever? And that might be a good starting point for these patients. here, as well as in a lot of guidelines, it is recommended to screen patients for MRSA or MSSA colonization. And this is especially true for patients who are going to undergo major clean surgery. So these are cardiothoracic, transplant, and implant surgeries. If patients in screening are positive, they do need to complete a 5 to 7 day decolonization bundle and retested after. And if you still find MRSA, for example, then when they are admitted, everyone needs to do contact precautions. You may need to add vancomycin to your recommended antibiotic prophylaxis protocol. If it's MSSA, usually your antibiotic prophylaxis will cover for it anyway. Right. So just by the fact that they need to complete a 5 to 7 day decolonization bundle means that you can't do screening on the day of admission 1 day prior to surgery. This needs to be done at least 2 weeks pre-op so that you will have time to identify if they are carriers, and then to prescribe to them this decolonization bundle. So just for your information, if you're not aware, it's 2% mupirocin intranasal ointment. We're including a chlorhexidine bath daily for 5 to 7 days. The chlorhexidine bath needs to not be like mandi kerbau kind of thing. It kind of needs to stay on the skin for at least 5 minutes before you rinse it off. And if patients are a little bit sensitive to chlorhexidine, then other decolonization agents that are quite commonly available are octinidine. So then when you come to the perioperative phase where the patient's about to be admitted, and as well as the immediate pre-op and the immediate post-op phase. So let's say even if you've screened the patients and they're not colonized with MRSA or MSSA, everyone needs to just undergo one quick decolonization protocol on the day of admission prior to surgery. So this includes shower, bathing, wiping, to reduce the colonization of the skin. It is not recommended anymore to shave, is to use hair clippers, because shaving may cause micro nicks in the skin, and that can introduce bacteria. So the ideal is get patients to shower at least once, but preferably twice pre-op. So I usually ask patients to bathe the night before and the morning of surgery. At the worst, is just use plain soap. But if you have available to you things like Surgibuff, Octinisan, etc., get them to use that. And then, of course, hair clipping is the preferred method and should be performed as close to time of surgery as possible. When it comes to antibiotic prophylaxis, the Malaysian guidelines, and actually all guidelines kind of say the choice should be based on your national guidelines in the country. In our hospital, we do have the PPUM antibiotic guidelines where they outline the prophylactic antibiotic of choice for different surgical procedures. So in orthopedics, our mainstay is cefazolin, which is a first generation cephalosporin. But if patients are allergic to penicillin, then clindamycin or vancomycin would do. As with all guidelines, they say the time of administration is important. It should be given within 30 to 60 minutes prior to incision. And if you're going to give an infusion, that needs to be started 2 hours before incision, because if you need to infuse over an hour, that infusion needs to be completed before surgery starts. You should redose if there's significant blood loss or extended OT time. And in most cases, single dose prophylaxis is enough. In orthopedics or surgeries that involve implants, should not be used more than 24 hours in clean cases. Hand washing, this is your scrubs with antiseptic solution, again, is the recommendation. In terms of highest efficacy and interactivity, chlorhexidine is the ideal. Of course, there's iodophos, triclosan, and again, in the worst case scenario, at least use plain soap. Your first scrub should be about 4 to 5 minutes long. Your subsequent scrubs can be shorter, provided your hands are not grossly dirty or you have not done something really dirty beforehand. If you're using alcohol-based hand rubs, you should clean off gross contamination first before you use the alcohol hand rubs. This is not available in our hospital. Not many hospitals in KKM even, I think, have this. So when it comes to surgical prep, there is no evidence that chlorhexidine or iodine is better over the other, but it is known that an alcohol-based solution is still better than an aqueous solution. So you should try to get chlorhexidine or povidone iodine in alcohol rather than aqueous. If you're using alcohol-based solutions, you must allow it to air dry. There have been case reports of patients suffering burns when the alcohol is, with the vapors, and then you use your diatomy, and then it sparks a flame. If you're using povidone iodine, there has to be a contact and drying time, and this allows free iodine release against the cell wall of microorganisms. And again, there are studies that show that if you allow your iodine to dry, there's a lower risk of infection versus, all wet and drippy iodine. It is recommended, if possible, to use iodophore impregnated incised drapes. Again, this will give continuous slow release of iodophores onto the skin surface. I know we're a teaching hospital, and on occasion, especially when we run courses, it looks something like this. But really, if you want to try and reduce surgical site infections, you do need to minimize the number of people in the room. If you have the sheer number, as in this picture, there's definitely no movement. But this OT traffic is well known to increased OT traffic is well known to have higher risk for SSI. Wounds should be irrigated. The late Prof. Sen used to say the solution to pollution is dilution. So we in orthopedics wash a lot to try and decrease the intraoperative bacterial load. You could use saline. You could use saline diluted with povidone iodine or betadine diluted within the mix. There's no consensus on volume. It should be procedure specific. And again, the method also, there's no consensus. Whether you use a pulse lavage gun or you just pour the water into the wound, or you use a bulb to spray onto it, as long as you're washing the wound. What is clear, though, you should not add antibiotics into your solution. It is not recommended for the purpose of preventing SSI. And certainly I do know of in some countries and in some surgical specialties, they do sprinkle vancomycin powder onto the surgical wound. This does not work. So please don't do it anymore, because it causes unnecessary risk of antimicrobial resistance. The patient needs to be warm, have good volume, and well oxygenated. Again, this will help to reduce tissue hypoxia and maintain a local immune response. And when it comes to wound closure, it is recommended, if you could, is to use triclosan-coated sutures, especially in patients who are at high risk of developing SSI, or in high-risk cases where you want to prevent SSI in the first place. This is not a must-have, certainly in the Malaysian guidelines, because we know that it may incur some costs for some hospitals. So if you can't have it for every patient in your hospital, then at least for the high-risk ones. When it comes to post-op wound care, people talk about all the different nice advanced dressings, but actually there's no, strong evidence to show one dressing is better over the other. What is important is to dressing change only when necessary. One is you want to reduce contamination or exposure to the environment. It's less painful for patients. And if you do dressing change, it has to be aseptic technique. Okay. And when it comes to surgical drains, if ideally use selectively. If you need to use it, you need to use it. It's not to say that you can't. You do need to look at the wound site on a regular basis to make sure there's no infection. And it is not an indication to prolong your antibiotics for the patients for patients who are still on drain. I know it's a lot. I don't know where to start. Well, one good way to go about it is to develop an SSI care bundle for your surgeries. So a care bundle comprises a set of key evidence-based interventions that improve patient care and outcome when you use together. So maybe you just change one thing, it might not change your infection rate, but if you bundle it with a few other things that you know works, they will tend to be more effective in reducing infection. It helps to standardize clinical practice. So surgeon A will practice one way. Well, if you have an SSI care bundle, then surgeon A to Z will have to do the same thing. There is no ideal SSI care bundle. You can't say, oh, hospital, X in UK is so great, I want to take the SSI care bundle. You need to customize it to your local situation. When developing a care bundle, remember I presented a lot of factors for SSI prevention. You don't need to change everything. Just pick the ones with the highest evidence to work. So the full stars in this slide means that it's strongly proven that if you optimize this, the SSI rates will fall. So like glucose control, using antimicrobial prophylaxis that is weight-based, using, let's say, appropriate hair removal, etc. So just a quick sharing of our experience with the infection control department. So this was a surveillance team that we set up in 2017, early 2018, which comprised the infection control, the surgeons, anesthetists, all the nursing from the ward to the OT, GA as well. So and I think in our team, we also had pharmacists as well as quality control people in the team. And what we wanted to look at was how do we reduce infections for closed lower limb fractures, patients who are coming for surgery. So first you had to go look for any gaps for improvement. And we found that, at that time in our survey, there was no standardized practice and documentation for pre-op bathing, hair management, surgical skin prep, antibiotic prophylaxis, as well as redosing. So our infection control nurse went in and did a retrospective audit, which found that our SSI rates before we introduced our SSI care bundle was about 8.7% over 3 months. And we say, okay, let's aim to reduce it by 50%. Let's just introduce these 4 measures. So make sure patient has a bath pre-op, there's clipping, you optimize the skin prep, whether you use chlorhexidine and alcohol or povidone dry and then alcohol, and then make sure the antibiotic prophylaxis is adhered to. And once we introduced the bundle, within a very, very short period of time, we managed to more than half our infection rate down to 3.3%. And this pilot project won the hospital the APSIC Safe Surgery Award in 2018. In our bundle, it shows a pre-op thing, but actually you can create a bundle even for wound closure. So in this particular paper by Charles Edmonston, they had a wound closure bundle where they said everyone had to change gloves and gown, maybe. You had a dedicated wound closure tray, you had to irrigate properly with chlorhexidine, use antimicrobial sutures, etc. So actually your bundle could, like I said, it's customized to your situation and needs. And you will find that there will be good improvements if everyone adheres to it. So to conclude, SSI are devastating complications of surgeries. They are preventable as long as we all know and understand the risk factors that contribute to SSI. We all take proactive steps towards preventing it. Adoption of a SSI care bundle will help. But most important is really teamwork, not just between the healthcare providers, but also with the patient when it comes to prevention of SSI. Thank you.
Okay, thank you so much, Prof. Azlina. I think there are 2 questions in the Q&A box. The first one is Yu Kun Cheng. I notice you prefer chlorhexidine for skin preparation, but when it comes to wound cleaning inside the operative site, iodine-related solutions are used. Is there any reason why we use chlorhexidine? Or chlorhexidine is avoided?
Why chlorhexidine is avoided? I don't know.
Yeah.
Most guidelines just say no. I think I don't know. I don't think it's very effective. Maybe they identify that it's not that effective once inside. I don't know. But having said that, remember the SSI care bundle closure tray that in my second last slide, in that particular situation, that surgeon used chlorhexidine diluted in saline to wash the wound. So I think most guidelines say povidone iodine or betadine. I wouldn't, and there are some articles that suggest that it helps, but I think it's not a very strong recommendation by WHO, CDC, etc. Everyone just says you kind of have to wash it, but in ortho they say using povidone is good enough. And
Yeah, I think
then
just put another feedback there. As an anesthetist, chlorhexidine has been implicated with nerve injury. I mean, I don't know, we never use that in the
we never use, but like I said, Chuck
operative.
Emiston uses chlorhexidine in his, but I think it also depends on the concentration of chlorhexidine. Obviously, you take a very high concentration, like 4% of chlorhexidine versus one that is 0.5%, your risk for toxicity is higher, probably. Okay.
Okay, Prof. Shireen, I think thanks for the talk on extremely important core topic in surgical care of patients. I find it difficult to get iodine impregnated adhesive covers for my patients.
You should get some from the Auto OT.
Yeah.
So in ortho, it's quite common to have the impregnated iodine impregnated apa tu covers.
Yep.
On occasion, I admit sometimes the hospital runs out of stock. So when it comes to implants, surgeries with implants, some implant companies bundle the
Yep.
the Ioban is the brand name. In this particular case, the one that we normally use is Ioban.
Yeah.
This iodine impregnated covers together with the implant bundle. So that's another way I guess you could go about it. I don't know whether Farm Selatan will be able to have it on the site so that if you can't get it in OT, get your patients to buy it from farm and then make sure that it's available for you for your case in OT. We have not used the ones that are not iodine impregnated, although I think when I started as a trainee lecturer many years ago, there were studies that show IDO4 versus non-IDO4 impregnated, and the IDO4 ones tend to have a lower SSI risk because of that constant contact of iodine on skin. They say that the iodine does penetrate a few millimeters into the skin rather than just being on the surface. And that's why they say ideally if you have it on for as long as possible. I know a lot of us also, before you close the skin, you start to peel off the edges. That's not the way to use it lah. That's the not proper way. So that's why we've never used the non-impregnated ones before. Happy to hear about the alcohol-based hand rubs. I hope that will come to fruition.
Yeah. Okay, I think we are just on time for the end of our sessions. I think we don't want to delay for the next session. Thank you so much, everyone, for listening.
Thank you.
Anything, you can always get in touch with us or Prof. Fazina specifically regarding the SSI care bundles. Okay, thank you.
Thank you. Or Prof.
and have a-
Sashila, not me only.
Yeah, Prof. Sheila.
Okay.
Okay.
Bye. Thanks.
Okay.